Greetings. I am Annie Augustin, President of the Atlantic City, New Jersey chapter of the Links Incorporated. Today's webinar is brought to you through an HIV Education, Leadership, and Prevention Program grant received from the Links Incorporated. Through this program, the Links Incorporated is supporting the development of new or expanding existing models and strategies for HIV education and prevention programming. The Atlantic City, New Jersey chapter is focused on assisting our community in this area with education to produce more responsible actions. We are pleased to be on this journey with two partners. With me today are Kara Jansen, representing the Atlantic County Division of Public Health and acting director in that organization, and Stacy Zakharoff, Vice President of the Theta Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated. Each in turn will tell you more about her specific organization. Kara.
Thank you so much, Annie. My name is Kara Jansen. I'm the Acting Division Director for Atlantic County Division of Public Health. The core mission for Atlantic County Public Health is to prevent disease, promote health, and protect the public's health. We accomplish this through offering services and resources to address the needs of the community. Through our community health unit, we investigate and track communicable diseases and outbreaks, including sexually transmitted diseases. Through health planning, information, and preparedness unit, we coordinate public health emergency planning, and we also communicate to providers essential public health alerts. Through the environmental health unit, we provide testing, inspections, and emergency response for environmental health hazards. Through our substance abuse support unit, we plan and coordinate drug and alcohol prevention and treatment programs. And through the animal shelter, we facilitate pet adoptions, provide education on responsible pet ownership, and provide housing for stray animals. The Atlantic County Division of Public Health is pleased to partner with the Links Incorporated Atlantic City chapter and the Alpha Kappa Alpha Sorority Theta Kappa Omega chapter. Thank you for having us participate in this worthwhile project.
Stacy, please.
Good evening. My name is Stacy Zakharoff, and I am the Vice President of Alpha Kappa Alpha Sorority Incorporated Theta Kappa Omega chapter. On behalf of our president, Mrs. Shawn F. Phillips, I bring you greetings. Alpha Kappa Alpha Sorority Incorporated is the first Black Greek-lettered organization established by African-American college-educated women, founded in Washington, D.C. in 1908. As an international service organization, its membership is comprised of nearly 300,000 members and approximately 1,018 graduate and undergraduate chapters throughout the United States, the Caribbean, and internationally. Theta Kappa Omega chapter was chartered in November of 1966 in Atlantic City, New Jersey. With currently 70 active members, we work tirelessly to uphold the sorority's mission of sisterhood, scholarship, and service. Under the program theme of exemplifying excellence through sustainable service, we are honored for this wonderful opportunity to collaborate with the Links Incorporated Atlantic City chapter, as well as the Atlantic County Division of Public Health, as we raise awareness and provide educational resources regarding HIV and AIDS. Theta Kappa Omega chapter is excited to be a part of this collaborative effort, especially since it focuses on our local community. Thank you for attending our webinar this evening.
Now, I am pleased to introduce Linda Flake, the moderator of today's panel. Linda Weiss Lake is the President, Chief Executive Officer of the Southern Jersey Family Medical Centers, a federally qualified healthcare center servicing Southern New Jersey. She is also an alumna member of the Atlantic City, New Jersey chapter of the Links Incorporated and the past chair of our Health and Human Services facet. She has worked in community health for almost 4 decades and is particularly interested in helping eliminate the disparities in healthcare for communities of color. If you have questions during our panel discussion, we ask that you use the Q&A function, and assisting Linda tonight with that will be Sharice Pfizer. Sharice is our current chair of the Health and Human Services facet. Sharice is Vice President of Clinical Services and the Chief Diversity, Equity, and Inclusion Officer with Atlantic Care, which comprises Atlantic Care Regional Health Services and Atlantic Care Regional Medical Center. In her clinical role, Sharice leads the system's healthcare diversity services lines, and as Chief Diversity, Equity, and Inclusion Officer, Sharice leads the development of a transformative diversity strategy to align with the organization's strategic plan. Linda will now introduce you to our 3 panelists for this evening, starting with Jean Haspel. Linda.
Thank you, Link Annie. Good evening, everyone. Jean Haspel is a nurse practitioner, HIV specialist at Atlantic Care. Haspel treats not only patients with HIV, but also hepatitis, substance use disorder, latent TB infection, and sexually transmitted infections. When it comes to substance use, HIV, hepatitis, these circles all overlap, she says. She has a bachelor's in science and nursing from Stockton University and is one of the first recipients of Atlantic Care's Advanced Nursing Practice Fellowship. She completed her Master's of Science degree in nursing at the University of Pennsylvania and is certified as an HIV specialist by the American Academy of HIV Medicine. Babette Richter is a registered nurse at Oasis Harm Reduction Center. Babette is a registered nurse working at the Oasis Harm Reduction Center in Atlantic City. She serves as the nursing team leader at Oasis. Babette has over 10 years experience working in harm reduction, serving those currently living with HIV, as well as those at high risk for acquiring HIV. Her team works closely with the Syringe Access Program, providing harm reduction services for both HIV positive clients, as well as those at risk for HIV acquisition. They provide rapid HIV, HCV, and syphilis testing, as well as STI testing and treatment, wound care, sexual and needle use, risk reduction education, pregnancy testing, and support, Narcan training, and kits for overdose response. And last but not least, we have Tricia Luco, who is a MAC counselor at John Brooks Recovery Center. Tricia is currently a MAC counselor at John Brooks Recovery Center, Atlantic City. The Recovery Center is a methadone maintenance program, though a handful of clients are on Suboxone. They provide psychoeducational groups, recovery coaches to assist clients through recovery and stages of change. Responsibilities include providing monthly reports to parole, probation, drug court, as well as DCP and P child protection services for clients that fall under these mandates. Tricia monitors the weekly drug screens and helps clients to achieve a stable dose of methadone, which varies from person to person. She meets with clients individually, which can vary from once a month or quarterly, depending on the client's phase level. We thank you and welcome you to our panel discussion tonight. And I think we're going to start with Jean and follow. Mary will follow behind her and talk a little bit about what you do every day. Thank you. Jean.
Thank you, Linda. And thank you for the opportunity to be here this evening to educate our community. As mentioned, I am a nurse practitioner, HIV specialist. I work for Atlantic Care Health System in our federally qualified health center. And in that capacity, not only am I treating patients with HIV, I treat patients living with hepatitis B and C. I also prescribe medication for HIV prevention, known as PrEP. I take care of patients who have been exposed to HIV, either through some type of assault or sexual contact, and need immediate post-exposure prophylaxis. And more recently, I've started treating patients with substance use disorder, whether they have alcohol use disorder or opiate use disorder. I provide those services not only for HIV positive patients, but for all patients. Our Ryan White funded clinic has been in existence since 1991. We currently serve 491 patients. We know that there are nearly 1,400 patients living in Atlantic County with HIV. We're one of the largest providers of HIV care. In our practice, we offer medical case management, non-medical case management, assistance with transportation. We have a community health worker. And we also have access to Atlantic Care in general. We have 3 primary care clinics right within our healthplex at 1401 Atlantic Avenue. So that's a little bit about what we're doing at the healthplex. So I'll let you move on to Babette.
Hi, thanks for the introduction again, Jean. South Jersey AIDS Alliance was established back in the early 80s, serving those that were HIV positive because of the stigma. These individuals had difficulty obtaining housing and food and just recognition in the community. So South Jersey AIDS Alliance was able to get some grants and raise some money to help this population. As we transitioned into the 2000s and we started getting a little bit of a handle on HIV and HIV transmission, we also expanded into prevention services. So we began working with the more high-risk populations, educating them on HIV awareness, prevention methods. We soon opened a syringe access program, and we're the first in the state to hand out clean syringes to help reduce the transmission through sharing of needles. I was fortunate enough in 2010, along with 4 other individuals, to be hired as an ARCH nurse serving the syringe access clients to provide those prevention services and services to help maintain health for both, again, those with HIV and those at risk for HIV. So in my current role, my team and I provide rapid HIV testing, rapid hepatitis C testing, STD testing and treatment, pregnancy testing, adult vaccinations. We do wound care. A lot of times we see abscesses in those that might be using drugs. And with some of our HIV positive clients who may have fallen out of care and are off their medications, they also might have some wounds that need to be tended to. We do provide referrals for HIV, hepatitis, and pregnancy ongoing care. We do a lot of risk reduction counseling, both for sex risk reduction and needle use risk reduction, as well as overdose prevention, where we give out Narcan kits and teach people how to save others by the use of those kits. But our primary focus is always going to be HIV prevention in both those that are currently positive, their families, friends, and those who are at high risk for HIV. So I'm pleased to be here today. I hope we can help educate you and teach you some prevention methods to move forward in your lives. Thanks for joining us.
And Trisha Lugo.
Hi, thank you for having me. My name is Trisha, and I'm currently working for John Brooks Recovery Center in Atlantic City. So John Brooks was an actual person who in the 60s struggled with his own heroin addiction and decided during incarceration that he was going to change his life. And he ended up receiving a lot of support from the community. This is back in the 60s, and started with a little storefront center in Atlantic City that actually grew. Now we have 3 facilities, one in Atlantic City, one in Pleasantville, and a brand new building in Mays Landing. And we offer methadone maintenance and or Suboxone, depending on the doctor's, that's the doctor's decision. To treat opioid addiction, we have outpatient, we have intensive outpatient, we have inpatient, both short-term and long-term. We also have detox. We offer Narcan, and we, as part of our assessment every year, we offer HIV and Hep C testing. And we usually, any positive results, we usually refer to Atlantic Care because they are the HIV, capital of Atlantic City. We also recently partnered with Atlantic Care to provide services for HIV and Hep C, which is a brand new program that John Brooks just took on recently out of our Pleasantville office. So we are now collaborating with them to provide treatment to our HIV positive and Hep C positive clients.
Thank you very much for those introductions and discussions about what you do every day. That's so important to our community. In layman's terms, what is HIV? Babette, can you answer that for me?
I will. I'll answer that one. So HIV is a virus that affects humans. That's the H in the HIV. The I is for immunodeficiency, meaning we have a deficient immune system. We're all familiar right now with COVID. COVID is a virus. HIV too is a virus. It's transmitted from one individual to another. And I'm sure we're going to have plenty of opportunities to talk about the different bodily fluids and methods of transmission. But in basics, HIV, human immunodeficiency virus.
And while you're at that point, how is it transferred? How is HIV transferred?
So there are 5 bodily fluids that we think about when we talk about HIV transmission. That's going to be for men, semen, and that includes the preseminal fluid, also known as cum, and vaginal secretions for women, anal secretions in a man or a woman, breast milk in a woman who might be infected with HIV, and blood. There are also 4 modes of transmission for those fluids, being sex, which includes oral, vaginal, and rectal sex, anal sex, needle sharing, and a lot of people think that's just for those that are injecting drugs, but we have to remember needle sharing can include tattoos and piercings that are not done in a professional shop, but are being done where some of that equipment might be shared among individuals, and that puts a person at risk. Mother to child transmission can happen during pregnancy, during the birth process, and through breast milk. And then blood transfusions, although our blood supply in the United States has been safe since 1992.
Thank you. And Jean, how is Atlantic County affected by HIV? What is the data?
So as I mentioned, we have 1,377 individuals living in Atlantic County with HIV. I can tell you that in New Jersey, we have 38,069 patients living with HIV. And nationally, we have 1.2 million individuals living with HIV. The good news is that for the most part, new cases are on the decline. However, we are still seeing a lot of new cases in Blacks and Hispanics, with the majority of new cases occurring in men who have sex with men.
So that brings me to what people are at risk for HIV?
So actually, all individuals are at risk for HIV. However, we're seeing, again, most of the transmission is occurring men who have sex with men, heterosexually, injection drug use, and then some other causes that don't fall into those categories. So they're the transmission risk categories, with MSM representing 53% of cases.
Okay, so Babette, you were talking about.
Can I take that one step further?
Yes, of course.
So that's absolutely true. And Jean is hitting on those really high risk populations. But sometimes I want to bring that down one level and say anyone who's had condomless sex with a partner of unknown HIV status is at risk. Anyone who's recently had an STI or has been diagnosed with TB, especially if they've had recurrent STIs. Anyone who's sharing those needles, whether it's to inject drugs or for other purposes, And also if they've shared any of what's called the works, that would be their syringe, their cotton, their cooker, their water. If they're sharing any of those products for injection, that's going to be an increased risk. So she has those statistics and she knows it a lot better than I do, but I like to remember some of the simple causes and bring those up to everybody's attention as well.
And thank you, Babette.
Thank you. Syringe distribution has become a hot topic in municipalities across New Jersey and Atlantic City. Today, according to the New Jersey Spotlight, New Jersey lawmakers are pressing forward to expand access to clean needle programs for opiate users to help reduce bloodborne infections like HIV. That would give the state more control over where to locate these programs. What do you think of the Not My Backyard issue? Do the clean needle programs work, and do they help to stop the spread of HIV? Who wants to take that question?
I think Tricia and I both could speak to that one.
Okay, well, let's go.
You know, the syringe access programs that are in place today, those areas were chosen because they had the highest rate of HIV transmission due to needle sharing. And they were established in those neighborhoods. I think many politicians and others that live in those neighborhoods do feel not in my backyard. But what they're not recognizing is a needle exchange doesn't bring people into the community to use drugs. It actually reduces the potential of sharing and infecting a neighborhood by giving them clean equipment and giving them a safe place to return their equipment. We talk about community viral load. Every person we can prevent from getting a new HIV infection is protecting the community as a whole. So our syringe access in Atlantic City, people might see those orange caps on the street and think, oh no, more syringes. But they need to recognize those orange caps recognize a clean syringe that was used and possibly to prevent a new infection from being transferred.
Do you have something to add, Trish? Did you have something to add?
I have to agree with that. She and I did work together for a long time. And we do see a lot of people returning their syringes, which let us know that, you know, people are taking this seriously in the community, and they are accessing those services that they need. So where there's a need, then they should have the access that they need. And that's what they're getting right now with South Jersey AIDS Alliance.
Thank you. Our goal is to reduce the spread of HIV in the Atlantic County community. Can you give us a few tips on how to reach those at highest risk, including school-age children, senior citizens, and young adults?
I'll go for that one. I think that it is important. The first problem I see is stigma. There's so much stigma. I think that it's important to get to children, young teenagers, people that are just coming into, their, reproduction and their sexuality, preteens. It's really important that they have this information. And there is so much stigma, not just with HIV, but with, any type of homosexuality. And people are afraid to come, how they say, out of the closet. And they're not getting this information because of the stigma. And I think that is probably the biggest barrier for reaching these young people that are, coming into their teenage years and into their sexuality, and they're not getting the correct information, and there's nobody to talk to because it's taboo. And even today I hear people when they talk about HIV, it's whispered, and these are among adults. So how uncomfortable are our preteens? We have to find a way to get around that stigma.
I'd like to add, I think it's very important for the family unit to discuss this and discuss this while their children are still preteens, and certainly discuss this when their children are, as Tricia was mentioning, starting to experiment with their sexuality, starting to experiment with their independence, right? They're growing. There's certainly great references at the CDC website cdc.gov/HIV. There's resources there for parents. There's resources there for schools. We can't put this all on the education system. It should certainly be covered, but we have to also go back and say to the parents, it is your responsibility. You raise your child, and you need to discuss how to protect yourself, how talk about sexuality. I have to say, every year I'm seeing more and more young men who have sex with men. I've seen more and more individuals coming out as transgender. There's always new terms to learn. So my belief is that it really needs to begin at home.
Thank you for that answer. Any ideas on how to encourage condom use among sexually active seniors that live in nursing homes, senior housing complexes, and assisted living communities?
That is definitely a harder one because we are talking about an adult population. We do mobile HIV testing in the community, and we have started going to some of those senior centers where we find that resistance. And I think it's about education, because we are 40 years into the HIV epidemic, and we meet with people that are over the age of 60 that still don't understand how HIV is transmitted, and that even if they were married for the last 40 years and their partner was too, but they both lost their spouses and now they're together, that they have to consider, have they had any other partners since then? And has that person ever been tested to know their status? When we talk about those things, they seem very surprised that they should have asked that question. And I like to tell them, the over 50 crowd has seen an uptick in infections because we tend to think, oh, at this age, I'm okay. And HIV does not discriminate on age, color, creed, or any other factor.
Race or economic status.
Right.
Right. Trish, you talked about a stigma. And so we know that stigma exists. What gave you the courage to become a spokeswoman? And how would you encourage others to step into the spotlight to help educate those in the community so that they get tested and treated if positive?
For me personally, I've just found that the more I disclosed it and the more I learned about it and talked about it and started to get into this field, the more empowered I felt. I say the word empowered, but it's probably an understatement. As much of an oxymoron as this probably is going to sound, that diagnosis pretty much saved my life. I was IV drug user. I was infected with HIV. I had advanced into the age stages. And I may not have done that, had the needle exchange a little sooner, right? But who knows? But it's very, very empowering. And I meet people in this line of work who, they've been diagnosed for, 10 plus years and their own families don't know. The people, their parents, there's like the closest people to them don't know. And I have even role played with some clients who got into a relationship with someone that they began to really care about, and they were just scared to death to tell them. And I try to let them know that, it's a great way to educate people. Not only can you disclose to that person you care about, but it's a wonderful opportunity to educate that person on what it is and what undetectable means. And even if the other person, doesn't have the best reaction, we're still an opportunity to educate somebody. And we really need to get that education out there. And it doesn't really matter how we do it. It needs to get out and take that opportunity. I just think that the more you do it, the more empowered that you become. And I think that became my new drug of choice, was that empowerment. Yeah.
In terms of prevention of HIV, it's important that partners share their HIV history, or that you take on a new partner that you are tested for. How do people go about doing that and have that discussion with their partner? That's the hardest thing, right? How do they do that?
I have always advised for safety first, because you don't know how somebody else is going to react to that information. So I suggest do it in a somewhat public place, whether it's a park or a restaurant. Probably doing it from your living room with no one home, and the knives next door in the kitchen are probably not the best idea. But a restaurant, a park, something like that. You always want to put your own safety first. And for me personally, I think the sooner the better. Some It's a whole different topic, but some states have their own laws about that. And I just think it's important to be upfront and to be honest. And you don't want to have some really strong feelings and fall in love with someone and start like a life. And then months later, the longer you go, the harder it becomes. And then you're kind of like living a lie. And I think it's just easier to be straightforward. One of the issues is, why is this so difficult to talk about? It's that stigma. Why is you're not, so hesitant to tell someone that you have diabetes or heart disease? Why is this so difficult 40 years into it? It should not be
It's
this
hard.
difficult to have that conversation. And that's one of the issues.
I would like to add, as a clinician, patients often ask me, what is the right time to have this discussion? I tell them definitely before there's any sexual activity, and not after. I've had patients actually bring their new partners in with them to meet me so that I can be there when they disclose, so that I can answer any questions. We definitely need to lower stigma, and we need to get the word out. If an individual has HIV and they're on medication and they are undetectable, we know that they are untransmissible. They cannot transmit HIV to their sexual partner. That being said, I often am told in instances, oh, my partner says they're undetectable, which I can't necessarily confirm that. But we do know individuals in care taking medication who are undetectable cannot transmit HIV. And with that knowledge, with that information, U equals you, we should be able to lower the stigma attached to it. I get very excited when we see celebrities or influential people who come out and who disclose their status. More recently, Billy Porter came out, disclosed his status. Recently, the gentleman who was in Hamilton on Broadway had come out, who was actually playing Hamilton. So the more individuals come out and declare that they're living with HIV, and again, living with HIV, hopefully we'll be able to lower the stigma and the mystery behind HIV.
Thank you for that. Now, how often should a person who is at risk for HIV be tested for HIV?
Well, I'd like to take that.
Okay.
So individual at risk minimally should be screened every 3 months. They should have HIV tests. They should be screened for sexually transmitted infections. In our practice, at baseline, we're screening for hepatitis A, B, and C. If they're not immune to hepatitis A and B, we are vaccinating. At this time, we have no vaccination for C. So sexually, transmitted disease clinics, OASIS, even our practice is, every 3 months.
Okay. Now, does a negative test mean that you don't have HIV?
So that's a great question, and it depends on the test. There are several different kinds of tests available. We have a blood test, and we also have a point of care test. Most tests today are the 4th generation HIV 1/2 antigen antibody tests. And those tests, whether it's serum or point of care, we know that it can pick up HIV about 10 days after the infective event. That antigen would be positive, and it can take 6 weeks for the antibody to be positive. So yes, there is a bit of a window period when you have tests done that I can't tell you absolutely today that you're not positive, but at least we know any activity you've had in the last 10 or 12 days, you're testing negative. I want to let you know, AtlantiCare does have the opportunity. We have literally a 1-minute test. It isn't just an antibody test, so that's going to test for 6 weeks to 3 months. If that's negative, then we know during that 6 weeks and 3 months that you've been, you're negative. But it's nice to have an answer in 1 minute.
Now that there is a post-exposure prophylaxis, PrEP, that can be used to prevent infection if used within 72 hours of a possible exposure, do you think the community at large is aware of that, and that the cost is covered by insurance, Medicaid, and are free or at very little cost to patients? Do you think our community needs to get that information, and how we be going about letting them know?
So I'm going to take that also. So
Okay.
first of all, there's post-exposure prophylaxis, and then there's PrEP. So if you've had a sexual assault, if you perhaps had sex with someone, you don't know their status, but or someone who maybe disclosed their HIV, not on meds, that would be a post-exposure prophylaxis type of situation. Most of that is started in the emergency room, where a patient has 72 hours to get started on a cocktail. Basically, they take an entire antiretroviral cocktail for 28 days. So there's that situation. And then there's individuals who feel they're at risk for HIV. They have unprotected sex, male or female. They're at high risk to acquire HIV. We would then discuss with that person taking HIV pre-exposure prophylaxis known as PrEP. So I don't have television, so I don't get to see what the commercials are, but I do believe there's a lot of commercials out there recommending that people get tested, and that if you're at risk, that there is preventative medication. And it is covered by insurance. And for those individuals who don't have insurance, they can get the medication through pharmaceutical assistance programs. So I can tell you that nationally, there's a huge push to get everyone at risk for HIV on PrEP. By doing that, that would be one of the tools that we can effectively end the HIV epidemic in the United States.
I think I have one more question that I'm going to ask, and I'm going to turn it over because we have about 8 questions that people want to ask on the Q&A. But we know that the rates of infection has increased, is highest amongst men. And then amongst men, the rate of infection is highest amongst Black and brown men. Why is there such disparate rate of infection?
Well, I think that's been true traditionally for the longest time. Again, I think stigma initially was highest among that population. I think that population has less access to the healthcare where they're going to be educated. They have less access to just the brochures that might be posted in places where a more affluent population might gather. So getting the information into those communities and into the hands of those people that need to see it needs to be a priority. And I know, again, 40 years into this epidemic, I don't understand why those materials and those education opportunities are still so lacking. I know in our office in particular, we do our best to take our mobile unit into the areas where we know that risk exists, to do both testing and education.
Yes, and that is what our program is about, trying to reach into the community and make them more aware of how we can prevent the spread of AIDS. So we're looking to the people who are working in that field to give us some guidance on terms of how to best spread that message. And with that, thank you very much. I'm going to flip it over to Sharice to ask the questions that are coming in from our guest. Sharice Pfizer.
Thank you, Linda. So I am going to start with the first question, which is, what is the difference between HIV and AIDS?
So I'd be happy to answer that. So we know that HIV is a virus that attacks the immune system. When the person's been living with HIV for a period of time, or could be anywhere from 10, 15, 20 years, we see that the virus is weakening their immune system. And when they hit certain parameters, such as their immune system becomes extremely weak, specifically that we know the virus is attacking and killing a CD4 cell. So a normal CD4 count is 359 to about 1500. When that CD4 count is below 200, or the percentage of that CD4 count is less than 14%, that person has immunological AIDS. Also, if a person is HIV affected and they develop what we call an opportunistic infection, known as such as PCP pneumonia, Mycobacterium avium complex, there's actually a total of 30 opportunistic infections, then they are said to also have the diagnosis of AIDS.
Okay, thank you. What activities are most likely to transmit HIV? I think you may have answered that question, but since it was in the Q&A, I just want to repeat it.
Absolutely. And there is the recognition that when we say sex is a transmittable mode of transmission, we say anal, oral, or vaginal sex. We recognize anal sex has the highest risk, whether you're receiving or inserting a top or a bottom, if you will, on the street. That's the highest risk, with vaginal sex being a similar risk but a lower risk. And finally, we would have, finally, we would have oral sex. And while that is the safest sex choice as far as risk reduction, there is a potential for an oral transmission. So we always want to cover all three areas, oral, anal, or vaginal sex, as being a risk factor.
Thank you very much.
I'd like to point out too that being under the influence definitely increases your risk because you're not making clear decisions. So
Yes.
if you're under the influence of drugs or alcohol, that is absolutely going to raise your inhibitions and put you at a greater risk.
Trish, I appreciate you saying that. One of the questions I have is, what if you have other sexually transmitted diseases? Does that put you at higher risk?
Absolutely. I'm going to let Jean take that one though. She's going to be better with that one than I am.
Yeah, so someone known to have sexually transmitted infections, including herpes simplex, including human papillomavirus, patients actually are more susceptible to acquiring HIV because of the changes in mucosal surfaces will put you at just at higher risk at the acquisition of HIV.
Thank you. So how common are false positives and or false negatives in HIV detection?
So I'm going to take that. I'm going to let you know that it is, I have seen a few false positive HIV tests in pregnant women. So it's something about pregnancy that causes them to have like a false positive HIV antibody test. The antigen will be negative, but the antibody's positive. Then we do additional testing, viral load, it's negative. And surprising you should answer that. Ask me that because just very recently I had a patient referred to me from our mission clinic, a gentleman who, same type of scenario, his antigen is negative, Western blot is positive, but he has no detectable viral load. So I'm actually doing a few more tests on him. I'm going to get a CD4 count so I can check that CD4, CD8 percentage. Luckily he doesn't seem too worried about it. I think we're more worried about it than he is, but it's not common. And like the cases I've seen mostly are in pregnant women.
And what about false negatives? Is that common?
No, actually. I mean, they're true negatives, really.
Okay.
Yeah.
So can HIV be detected with a pap smear?
It cannot. No, it absolutely no. You have to specifically look for the HIV 1/2 antigen or antibody or viral load to diagnose. So a pap smear course, is, they're taking some cells off the cervix and looking under a microscope, looking for abnormal cells. However, if a woman is diagnosed perhaps with some type of invasive cancer, HPV, that might lead the clinician to then order additional testing such as HIV.
So do you have to sign a consent to get an HIV test?
In the state of New Jersey, the method now is really opt out. So as a clinician, and I'm meeting a patient not known to me to be HIV positive, what we're doing is I inform them that I'm going to be screening you for HIV, hepatitis B and C, tuberculosis, sexually transmitted infections. They have the right to opt out. They can say, no, I don't want that test done. So, when they come in for care, they sign back of their registration form, which is a blanket consent for treatment. Years ago, it did require a separate consent form, but no longer.
So as a clinician, are you required to share with them that you're testing them for HIV?
I am required to tell them that I'm testing them for HIV.
Okay, thank you. And how accurate are the in-home HIV tests?
They're as accurate as the ones that we're using in our office. They are the same 4th generation test out there. My only concern with a home test is somebody hearing that result on their own. And yet I know I had a gentleman come and test with me who turned out to be positive, who said he never would have tested had he not done a home test first. So I think they are a great addition to our arsenal for people to be able to self-identify and get the help they need.
Thank you. So how long after an infection or how long after you've been exposed does it take for symptoms to appear?
So since we're dealing with a viral infection, patients can have symptoms. Some patients have symptoms within days of the infective event, probably within 7 to 10 days. Many patients develop like a flu-like illness, and we are just, still in a pandemic situation, but there are patients who present themselves to the emergency room with flu-like symptoms. And historically, it was a opportunity, a missed opportunity amongst, ER providers by not testing for HIV. And that's why the state of New Jersey decided to put rapid HIV testing in majority of emergency rooms.
So the next question that's in the chat and the final question that's in the chat actually, I think has been answered. And that was, is there a difference between HIV and AIDS? And I think that was answered earlier. So that concludes the questions that are in our Q&A. So Link Annie, I'm going to turn it back over to you to close this out.
Thank you so much, Linda and Sharice, for moderating our discussion this evening. And thank you to our panelists, Babette, Tricia, and Jean, for your discussions. I'd like to welcome Kara and Stacy back to the stage as we close out, our partners. I think you are still on as panelists. If you could, there they are. And if you could highlight them to our technologist people, thank you. So that was a very informative discussion, and we'll make it available on our YouTube channel to be viewed by others. Thank you so much to those who were able to join us on today. Make sure you continue to look for us. The Atlantic City, New Jersey chapter of the Links Incorporated, the Theta Kappa Omega chapter of Alpha Kappa Alpha Sorority Incorporated, and the Atlantic County Division of Public Health. We'll be working together in your community to continue to address HIV/AIDS and other pressing issues. So thank you so much for joining us this evening and have a great night. Thank you.